Hello, everybody. I'm Dr. Joe Goldberg. I'm a clinical professor of psychiatry at the Icahn School of Medicine at Mount Sinai in New York. I'm a field editor at the Journal of Clinical Psychiatry and a board member of the ASCP. And today, we're going to be talking about the topic of how to review a journal paper, key methodology concepts for informed readers and reviewers. I'm going to take us through what is the art and excitement of actually getting into a journal paper with the mindset of a reviewer, whether you're an actual reviewer being tapped by an editor to review a paper, or even just a very curious and want to be very informed reader, critical reader of the literature. Hopefully the comments we're going to go through today will make the task of reading the peer-reviewed literature all the more engaging, thought-provoking, and useful. So may I suggest, as a reviewer, adopting the mindset, if you're a mental health clinician, the mindset of assessing a patient in an emergency room or otherwise emergent setting and evaluating their mental status, because the skill set that we bring to bear in assessing a paper is not that different from assessing the clinical features that we hear about from a patient who may even present in a crisis or at least for urgent attention. So the chief complaint is really the main thesis. You almost want to ask the paper, why are you here? What brought you here today? What's the background and the context? And what's sort of the main issue that's going on? If when you read through the abstract and a first pass through a paper, you don't have a very clear sense of what is the author trying to communicate in a very clear sense, that's a red flag right at the outset. And if you're writing a paper, you want the reader and reviewer to not in any way struggle to understand what is your thesis, what are you trying to say, and be very transparent about that. So kind of a first off the bat chief complaint, and then the presentation. So just like with a patient, we're looking at form and content of equal importance. The form of the presentation, is it organized? Is there an a priori hypothesis and a cogent presentation of a hypothesis-driven story, a narrative? We love papers that tell stories, and we have to struggle with papers where we're, again, trying to ferret out what are the authors trying to say, what is their main thesis, and is the argument that they're presenting in their background, in their results section, and their discussion supportive of the thesis. So you're looking for an organizational tone. That also includes quality of writing and communication. You sort of get points for that, but it's almost to be expected that you'll communicate your point in a linear fashion. We often are less enthusiastic about papers where, again, there's the struggle to figure out what are they trying to say. It's not exactly the same thing as grammar and language and spelling. Those count, but copy editors usually catch those kinds of things. So if you're a reviewer, you're looking for a coherent narrative story. Then the content is what the authors have to say. Is it plausible? Is it compelling? Is it logical? Is it of interest to the readership? And all important, is it a fit for this journal? If you're reviewing a journal that's very key to methodology, you'll pay far more attention to some of the statistical methods. If you're reviewing a paper that's more of a services paper, you're not less concerned with methodology, but you're especially concerned with the implications of that paper for services research. If it's a neuroscience-oriented paper, likewise. If it's a psychosocial outcomes paper, so I was sort of thinking, does this befit the readership of this journal? Hopefully, if you've been asked to review a paper, it's because you're familiar with the journal and you kind of have a sense of the clientele that visits this journal. General appearance, disheveled paper. There's no clear hypothesis. There's no guiding principle. And again, you're struggling. Your enthusiasm wanes quickly. Corroborative history, just like the patient in the ER, we look to collateral historians. What do other people have to say? The authors claim that it is very important to study the underappreciated implications of foot fungus on some outcome measure. Is that true? Is there some basis for this in literature? Is this a novel idea? So it's the job of the author to set the context in the introduction as to why they're doing this study and why is it important and why do we care? They want to make us care. Consistency, again, well-constructed narrative, compelling conclusions. As a reviewer, Here you sort of put on your detective cap. You're looking for contradictory statements or statements that are not supported. I could think of papers that I've reviewed where the results talk about a defined set of evidence that comes through. And then the discussion goes off and starts to hypothesize about what does that mean about brain function or about neural circuitry, which you give them a little latitude, but they really can't stray too far beyond the confines of the content. Or if they find something, let's suppose they're talking about bipolar disorder, an area that I've spent much of my career studying, and their paper's all about treatment effects in mania, but then in the discussion, they're talking about effects on depression without having discussed depression. So you point out contradictions and really want to speak to whether the conclusions are warranted and supported by the data. Is the presentation credible? Is it believable? All of our patients got better. There was no dropout over a 5-year period and no side effects. So we'll talk more about that as you go along. Implications for the field, the so what factor. Has this been covered before? As you're scanning the references, to the best of your knowledge, has anything been left out? Is it placed in the right context? And then the dispo. So in the ER, do we admit? In journals, that means accept. Do we discharge? That means we are going to pass on this, and you may want to send it elsewhere, but not here. Or what I'll call the holding bed, which is revise and resubmit, come back, make some changes, and we'll have another look at it, which is a very common disposition for a lot of papers. Right, so why should you review a journal paper? Well, you're being acknowledged for your expertise. Certainly in the eyes of the editor of the journal, you have been identified as someone who's made contributions yourself to the field, implying you know the area. And so you bring to bear that level of expertise. This is your area. It comes with great responsibility, right? You can influence the field. You may bring to bear a knowledge base that many other people would not. You can influence the field in large part by what you think about the paper. So I've had instances where I've called the editor of the journal to say, you know, I really think this paper I reviewed is spectacular. It's a real contribution. It's not an incremental advance. It's very meaningful. Really think you should publish it. And the editor says, yeah, I know already. Or likewise, in the confidential comments to an editor that appear on review forms, where you're allowed to say, you know, sort of things you want just the editor to know. You might say things like, you know, I really don't think this is up to par. I think it would take an awful lot of work to revise this. I really don't think it's a contribution. So your vote really counts for a lot. Reviewing a paper is a great way to learn cutting edge information on a topic. I sometimes feel like I'm ahead of the curve because I got to read something that other people may not so well know about and really have to delve into it. So it's a great learning experience. And you know, hopefully you find the topic interesting and the study interesting, because if you don't, other people might not either. Right? Why should you not review a paper? It's not your area. You have a conflict of interest. What's a conflict of interest? It's your boss's study. It's a study that you were involved in collecting data for, and you have some very direct competing interest. It's with a proprietary molecule or compound that you have some vested interest in or conflict of interest. Or you can't complete the review in a timely fashion. So, you know, people like to keep things moving along. One can ask for extensions of time, but these would be some of the factors. Just because you know an author doesn't mean it's a conflict, especially in a small field area where everybody kind of knows everybody, but you don't want to be sort of direct collaborators, certainly on a given project. On the other hand, you may have knowledge about the topic that others wouldn't, and just because you happen to know the authors doesn't negate your value. So let's call this a general approach. We're going to talk some generalities, then we're going to go into some particulars and examples about good and bad things when you're reviewing a paper, and then we'll kind of wrap up from there. So many would say, get a general sense, read the abstract. You never ever want to just read the abstract. That's a taste. That's the appetizer, right? So read the abstract, look at the figures and tables, just see, are these the kind of things that look like they go on forever and ever, and no one's going to want to read them, or they catch your eye. And then you'll do a first read through the paper for a kind of an initial impression, then put it away. Come back to it for a second deeper look where you'll want to annotate and make comments along the way. And then ask yourself again, in a general sense, is this an explicitly stated purposeful study? Is it compelling? And then you really want to sort of get into the, you know, is this a contribution? is the method section sound? If I had to pick, I guess the first thing I'd want to really pay attention to is the method section, just to get an idea of, was this study designed to answer the question that the authors claim they want to answer? Who's the sample? Are they well described? Are there enough patients to detect with adequate power the variable of interest? Is their analytic plan appropriate, or was it kind of pulled together? Are there any fatal flaws, as it's called? This is the wrong study design. You can't use a retrospective design for this. You can't get information about X from Y. It's underpowered. You have ethical concerns, plagiarism, even self-plagiarism. It's a no-no. Conclusions reach beyond the data. Fatal flaws, or as the name implies, fatal flaws. How's the writing style of the conclusions justified? So then you want to get a little more into what kind of study is this. So we think about prospective studies where you are starting from scratch and then going forward in time to observe things, or retrospective studies looking backwards in time. And you can get different findings there. I'm going to give you an example of that right now. So in the world of bipolar disorder, antidepressant-induced mania. Here's a meta-analysis. We'll talk about meta-analyses in a bit. Side by side from this excellent large meta-analysis, we get very different results if one is looking at retrospectively ascertained switch into mania. Notice of these 15 retrospective studies, get about a 31% incident rate of antidepressants causing mania. But if you look only at prospective studies, that's about half that amount. So the methodology really matters. And this is a clinically important point. A lot of people make key decisions on, are antidepressants safe or not safe? Vastly different results if the methodology was retrospective or prospective, right? So we like prospective studies. Longitudinal, course over time, cross-sectional, one point in time. Is this an interventional study, an observational study, or both? An observational, interventional study. I've intervened with some pharmaceutical or procedure, and then I will observe, let's say, biomarkers, imaging, or proteomics, or phenomenology over the course of time. And you'd like to see that there's some resonance between those things. Intervention studies, especially randomized studies, are considered gold standard, but sometimes observational studies are necessary. No one's ever going to do a randomized trial of whether defibrillation is a good thing for ventricular fibrillation, right? In certain life-threatening situations, observational studies become very important. Recent publication talking about ECT having lots of observational studies and not so many randomized studies. It can be argued that when there's a very big effect for something, a randomized study is useful to compare a known treatment to a comparator, but not to a placebo. And so observational just means we haven't controlled for the treatment itself. We're just observing how things go. And while that's not in general considered as useful for determining causality, does this intervention do better than a comparator? There are ways one can control for factors, even in an observational study, as we'll go forward. Can't say enough about a priori hypotheses and analyses. As compared to post hoc analyses and secondary analyses. So post hoc, after the fact. The data is already collected, and now I want to go do some additional analyses. Those are by definition exploratory. So you really can't make them the mainstay of your study. You can't say we ran the horse race, and now we looked at the 3 horses that came in first, second, and third, and now we want to look more carefully at them. They already won the race, so there's a bias introduced by the fact that the study's already finished. You can ask, I wonder if the horse that won the race was wearing a blue saddle. But then you can't go backwards and say, horses that wear blue saddles win races, right? Because that's a post hoc analysis. You'd have to start with that hypothesis, which brings to the notion of hypothesis generating versus hypothesis testing studies. Say more about that in just a second. So post hoc analyses are okay, but you want to be very conscious of that. If you're reading a paper, is this the a priori intended analysis or a post hoc analysis? And if it's post hoc, it's fine. You just want to be explicit about that and not run off and say, gee, I read that horses that wear blue saddles are the ones likely to win the race. That's not accurate to say. A secondary analysis is I want to look at a different question than this study was set up to do. So I have a big study looking at outcome in depression. And along the way, I collected data on smoking status or weight changes. And I want to do a secondary analysis, not on the main hypothesis, but on some side issue, right? So that's fair. And that may also inspire other studies down the road. Post hoc analyses and secondary analyses are often both useful for generating hypotheses, not testing hypotheses, that then some future investigation will look at in a more broad way. When you read a paper and the authors are explicit in stating this is a post hoc or a secondary analysis, it's very comforting when in the discussion they point that out. This is a preliminary finding, needs to be replicated with larger a priori design studies. That endears me to a paper. Proof of concept preliminary. So a small randomized trial. Proof of concept doesn't mean go run with the ball and now go out and do this. So let me give a little more examples. This notion of hypothesis testing versus hypothesis generating. So again, I start with a hypothesis. I design my study in order to tell if the thing I think is different from random chance, in fact, is. I have to design my study with the right variables, with the right methodology, with enough subjects, as opposed to, oh my God, who knew? Blue Saddles won the race. I've now generated a hypothesis. I encourage people to read anything you find by Chitu Andrade. He's one of the writers often appearing in the Journal of Clinical Psychiatry. Not to gush, but just very, very thoughtful writer and methodology and sort of sees through issues. He has a number of papers. This is one example, just talking about cherry picking data or hypothesizing after the results are known. So I give you the reference here just to have a look. It's very, very useful and informative. Again, we're not against hypothesis generating studies, but we don't want to masquerade them as if they were hypothesis testing. A few core concepts here. So you probably know in statistics, a type 1 error, that's a false positive. So I wrongly rejected the null hypothesis. Nothing's going on here, but I think I found something. That's also called the alpha level, right? Which we think of as the p-value. Type 2 error is a false negative. I wrongly accept the null hypothesis. I don't think anything is going on when in fact there really is something going on. So these are important distinctions to make. We'll say more in a second. Related construct effect sizes, how clinically meaningful is a difference? Type 1 and type 2 errors tell you if the difference that's being reported is different from what you'd expect to see by random chance. When a p-value, the alpha level is set at 0.05, that means 95 times out of 100, this is what you will see, okay? And so the findings we embrace as being likely accurate because they've been less than the p-value, the alpha level. But that doesn't really tell you how meaningful the difference is, how clinically meaningful. If I have two interventions and one is significantly better than the other, but it's an incremental change. Let's suppose on a depression scale, the Montgomery-Åsberg depression scale score goes from 30 to 27. That might be a statistically significant difference, but at 27 is still pretty depressed. So this is where effect sizes come in. For a continuous variable, like a depression scale, we talk about the effect size. Often that's Cohen's D, or there's another concept called Hedges G. That's a decimal. Typically, a small effect size or a medium or a large effect size is calculable. It is the change in mean scores divided by the pooled standard deviation. You can calculate these online. Papers will do this. I sometimes, when reviewing a paper, will calculate my own Cohen's D with an online calculator. And if I find, gee, there's a significant difference, but the clinical meaningfulness is real small, the effect size is 0.18, that tells me that the authors are making more of this than they probably ought to. For categorical variables like response or remission, you can calculate the number needed to treat, NNT. Less is more. The National Institute for Clinical Excellence, NICE, says NNTs under 10 are clinically meaningful. So if they don't provide this in the paper, you can calculate it yourself. 1 divided by the treatment group response rate or remission rate, or whatever rate you're interested in, minus 1 divided by the control group rate. And again, you'd like a teeny NNT. And for NNH, the number needed to harm, you'd like that very high. Let's suppose you're looking at adverse effects. The authors present their data and they say the most common side effects were this, this, and this. What's the NNH? So with a very antihistaminergic drug, the NNH might be a single digit. Single digit NNHs are not good. We like very high. You have to treat a lot of people before you're going to see this adverse effect. The obverse from NNT, we like it very low. Think of anesthesia. We'd like an NNT of 1, right? The chance that you're going to go to sleep with general anesthesia, you have to treat one person to get that effect. We don't have those numbers in psychiatry. We have single digits, double digits, we're not as keen on. So again, you as the reviewer or the reader get some context about this. So I just mentioned power. Are there enough subjects available to draw the inferences with validity that the authors are claiming they want you to believe? So the alpha level, that's the chance of a type 1 error. Usually we set that at 5%. Beta, the rate of type 2 errors, 20% is customary. So power is 1 minus beta. Usually that comes out as 0.80. If alpha is at 0.05 and beta is at 0.20, we say there's adequate power, meaning 0.80, to detect the differences we see. Type 1 errors are considered more serious. If you make the mistake, remember, of a false positive and you reject the null, that could be disastrous. A false negative is certainly not a good thing either, but a false positive would be really potentially disastrous. So power analysis, you always look in the method section, how did the authors decide the sample size? In a proof of concept study, that may not be feasible. The authors may say, we recruited 30 subjects per arm. And then you'll wonder, well, that may be enough to detect a large effect. Remember, go back to Cohen's D. A large effect, 0.80 or greater, that'd be like ketamine for depression, or lisdexamfetamine for ADHD is a large effect. A lot of our SSRIs have medium effects or small effects, meaning you'll need a larger sample size to see the effect. So you're always thinking, if the authors have a smallish sample size, but they find a big effect, is that a fluke? And if they have a smaller sample size, they don't find an effect, is that a fluke? The bigger the power, the greater the likelihood of seeing a meaningful effect. When there's a comparison between an active drug and some comparator, we also ask whether the analyses were set up to show superiority. My drug beats a placebo, or non-inferiority. My drug is no worse than the standard drug. So I have a new antidepressant, I'm going to compare it to an SSRI. I have a new atypical antipsychotic, I'm going to compare it to an existing atypical antipsychotic. Non-inferiority analyses mean that neither treatment is worse than the other. But that's fine, because when you think about it, if you've got two potent treatments and there's a difference, it's likely a small difference. King Kong versus Godzilla. You'd need enormous power to be able to detect a difference. So non-inferiority makes sense. Superiority makes sense when the comparator is not considered to be an active treatment. Then we have this concept known as assay sensitivity. So what happens if my drug doesn't beat the placebo? How do I know if that was a negative study, my drug just didn't work, or if it was what we'll call a failed study? That means that the placebo effect was unexpectedly high. That's shown in this example. Ever wonder why divalproex is not FDA approved for maintenance treatment in bipolar disorder? It's because of this study. This study found that if you compare recently manic patients on divalproex or placebo, you saw no difference. And if you had lithium as the active comparator for assay sensitivity, you find lithium didn't separate from placebo either. Yikes, what does that mean? Because it means that placebo worked in 40% of patients for 1 year. That's very impressive. So when there's a high placebo response, it's nice to have an active comparator for assay sensitivity purposes. Not to compare my active drug divalproex to the comparator, lithium, but to make sure that the study's not a dud. Inclusion of lithium in this arm meant the study was a dud. We'll talk about why in just a couple of minutes. It had to do with enrichment of the sample. But a negative trial means the drug did not work. A failed trial means I failed to see a difference from placebo because the placebo effect was unexpectedly high. Even the drug I expected to work for assay sensitivity failed to do so. When you have a lot of variables, we often will see univariate analyses, and then those may look to account for their mutual contributions in the outcome. of some dependent variable with some form or other of regression. We often think of logistic regression. That's where there's a binary dependent variable. So hospitalization, yes, no, remission, yes, no, suicide attempt, yes, no, and you get an odds ratio with a confidence interval that tells you how narrow or wide the actual value is. If we have an outcome measure that's a continuous variable, number of suicide attempts, number of ER visits, change in score on your BPRS or PAN score. Continuous variables, we look at a linear regression. And there, we don't get odds ratios, we get two things of importance. One is called the proportion of explained variance, or R squared. The higher, the better. If you throw all your variables as independent variables into a linear regression to try to predict your continuous outcome, and you get a high R squared, say 0.4, 0.5, wow, that means like about half of the variation you see in your variable of interest is explainable by this model, by these variables. That's very nice. Sometimes authors will say, we sequentially took out one variable and put in another, and it did or did not improve the goodness of fit. When I read that, I'm thinking they're really thinking about, how do I explain the phenomenon in front of me? I'm compelled as a reader or reviewer when they tell a story that way. They don't just say, we threw everything in the blender, put it on pulse, throw all the variables in. No, we tested hypotheses. Now, here's an important point when you're looking at regression, something called the 1 in 10 rule. For every 10 patients, you're allowed one independent variable. So if you're looking at a regression model and they threw everything in the kitchen sink, and we looked at age, sex, race, education, baseline severity, number of prior episodes, serum BDNF levels, CRP levels, and you've got 10 variables with 50 patients, fatal flaw, you don't have enough power. Which means that if you get a substantially high R squared, and the betas in the linear regression would be partial correlation coefficients, you get very suspicious that this is a fluke. This could be a false positive because you're underpowered. So big question sometimes comes up. If you don't get a finding, you might ask yourself as a reviewer, gee, could there be a real finding here, but it was underpowered? But then you counter ask yourself, well, but if there's a real finding, maybe the effect is small. So let's say they have a large number of subjects. The power analysis says we needed 70 per arm, and they enroll that many, but they don't see a difference. It doesn't negate the possibility that the drug or the intervention works, but it implies to you as the reviewer, if this thing does work, it's a small effect. The change in mean scores divided by the pool standard deviation, the Cohen's d is going to be small, which goes back to the so what factor or the who cares factor. And you write that to the editor. You say, gee, I'm concerned that the clinical meaningfulness of this is so tiny that even if they had a larger sample, all it would do is serve to show that this is not a very meaningful impact. You are doing the field and the editors such a service when you point things out like that. It is a very helpful critical comment for a critical reader. There's this notion called collinearity. When you throw all your variables, independent variables, into a correlation, if they're all correlated with each other, you could have great difficulty in saying, look, variable number 3 and number 6 was explanatory. My outcome measure is some bad psychopathological event, and suicide and chronicity and number of past episodes are all significant. But if they're correlated amongst each other, if they're collinear, then you don't really know which of them is most important. So you'll sometimes say to the editor or the author, I'm concerned about potential collinearity. Conceptually, it seems to me that these variables that you put in your regression equation might be linked to one another. Could you please check for collinearity? And if they do, when they come back and say, no, they're actually not related in univariate analyses, now you've strengthened the methodology of the paper and you feel good because you've made such a great contribution. Okay, p-values. So alpha level, the chance that I'm going to reject the null hypothesis, that 95 times out of 100, this thing that I just did is going to happen again. That's good if I do one study. What if I do 2 tests or 3 tests or 10 tests? Multiple comparisons or simultaneous inference or multiplicity means you can't just take the p-value at face value and say, look, I did 10 different tests and all these ones came back positive. It's like in medicine, when you order a comprehensive metabolic profile with 20 tests with a p-value of 0.05, one of those tests is going to come back as a false positive by random chance. That's why we have to rerun them, right? In psychometrics, we do correction for simultaneous inference. The conservative approach that people often talk about is called the Bonferroni correction. That means you take the p-value and you divide it by the number of variables that you're looking at. And that brings the p-value way down depending on the number of tests you've done, but that's the most rigorous way to do it. Otherwise, you have what are called nominal p-values. That's okay if you're doing an exploratory study and you say, we didn't correct for multiple comparisons because this is an exploratory analysis. And that's legit. And if I read those words in the method, I am reassured about the credibility of the narrative because I know the authors are not trying to misrepresent their information. Let's give you some examples. Let's skip this. Let's talk about the consort diagram. This standard diagram shows you everybody that came into the study at the front end and did they get excluded. So by the time you wind up with who got randomized or studied, you look to see who's missing. So this bears on what we're talking about as far as missing information. Let's take Dr. Andrade has a nice paper on consort diagrams. You can have a look in 2015 in J. Clin Psych. So here's a real life example. So here's a study with quetiapine that enrolled close to 2,000 patients. And look, all these people got kicked out. We don't even know how many got screened. That's an even bigger number. But of those who were screened, nearly 2,000 enrolled. A lot of them just prematurely discontinued during pre-randomization. Why? We don't know. Or they weren't eligible, they had an adverse effect. So if you're the clinician, you're reading the study and you want to say, all right, what happens to the completers? You're the randomized people, the ones who started out on drug versus placebo, but even some of them got lost, premature discontinuation, they had a mood event, they had side effects. So by the time you're at the end, you have completers. 9% of the people that started out completed and 2/3 who enrolled never got randomized. So it doesn't negate the findings at all, but it does bear on generalizability because the people that you're going to read about represent a little less than 10% of the patients that you as a clinician may actually be treating. It's very nice when a study sort of points those things out. This would be called effectiveness. That is under real world conditions, not just does the drug work, but when you account for things like dropout and side effects, loss to follow-up, withdrawal of consent, because this is a huge gap between the best of possible outcomes called efficacy and the real world outcomes that we see. Remember the Katie study years back in schizophrenia was an effectiveness study. They just looked at reasons for all-cause dropout. They didn't even get into the drug work. They said, for whatever reason, if you don't make it to the finish line, that was our outcome measure. Very real world. Nice point to consider, right? Let's talk about confounding factors. I want to try to keep this in an organized way. When you're reading a paper and you're looking at elements that go into the outcome that you see, you want to pay attention to anything that could interfere with the outcome. I think these patients who got this intervention had this change in some measure of psychopathology in an intervention study. Did the authors account for things like medication, baseline severity, what we'll call stratification? That means there could be differences across sex or ethnicity, or in pharmacogenetics, the allele frequencies in people of Caucasian ethnicity are different from people from Southeast Asian geographic origins or South African origins. So you might ask, is the population generalizable, or was this a strict focus on any one subtype without generalizability? Illness subtype, this is a big one. We call these moderators, factors that will influence outcomes. So I'm doing a bipolar study and I just threw in everybody. Bipolar 1, bipolar 2, cyclothymic, bipolar unspecified, and I expect to see similar results across such heterogeneity, or I'm looking at schizophrenia patients and I include chronic with acute, or I include those with comorbidities or not comorbidities, or the people that have been sick for 10 years versus 1 year. So this level of heterogeneity is important. And if you, as you're reading through a study, wonder to yourself, gee, they didn't find something, but in my clinical experience, they should have. I wonder if there's a confounding effect, let's say, of adherence or cognition or something you might just think of based on your experience and your expertise. You might suggest that. Could you consider doing a moderator analysis to see if chronicity might have been a factor here? And you have to think about the trial duration versus natural course of illness, like bipolar depression. The average duration of an episode is about 5 months. So if I do an intervention study and I don't find a difference from placebo, I might ask, did you account for duration of the episode? Because if there was any stratification or confounding, meaning some patients have been sick for 4 months, some have been sick for 1 month, I hope that that's randomized. Randomization should make that even, but they can control for that in a variable and say, with the two treatment groups matched successfully or randomized successfully on factors that I think might influence the outcome. If patients in the placebo arm were ill closer to 5 months and people in the treatment arm were ill shorter, the placebo effect may be unusually high. Or if the groups are not matched on baseline severity, the placebo effect may be very high because low severity inflates placebo effect. So here's where you're playing detective and trying to figure out if the patients allocated to the different treatment groups are matched or not. Crossover designs are when you take two groups and you treat them both with intervention, then you cross them over and you give the other group the other intervention. And the problem with that is you get what are called crossover effects. They're not as clean as just randomized comparisons with one treatment group versus another, because you don't know if the effects seen after the second phase are comparable to the first phase. So when you read about a crossover design, it's get a little suspicious. Let's talk about how you make comparisons when we talk about confidence intervals. That is the range with which the actual values of something occurs. Important things to keep in mind when you're reading a paper. If a confidence interval crosses 0, it's not significant. So that means that if any of these, if any of these antipsychotics had a line that crossed 0, none of them does, aripiprazole gets close, you'd have to say, this is not a significant effect. The confidence interval includes 0, doesn't count, it's non-significant. The second thing to consider is whether confidence intervals overlap. So this very nice study of antipsychotics and mania by Roy Perlis years ago showed all these drugs, maybe you have your favorite, but you know what? Their confidence intervals all overlap, which means that you can't really make a claim of superiority. You could maybe say, maybe there's a slightly bigger effect with some drugs than others, but if the confidence intervals overlap, you can't make claims of superiority. This is important sometimes when you're looking at a retrospective study or a claims-based study, and they tell you this horse one came in first, this one came in second. You want to look at the confidence intervals and see if they overlap, because if they do, you can't make those claims. Right? This is a slide that talks about whether you can assume a normal distribution or not, using what are called parametric tests and non-parametric tests. I think I'm not going to go through this in the interest of time, but you can have a look at this, a lovely book that came out not long ago, this year, Practical Psychopharmacology, got that name wrong, Practical Psychopharmacology is taken from that book and talks a lot about these methodologic pieces. Some more points about study effects. You have a very small sample size, you may get a very large effect. Think of a baseball player in the first few at-bats who connects with the ball and is batting .750. Come back later in the season, they won't be batting .750. Small sample sizes, not a lot of at-bats, not a lot of subjects, runs the risk of sometimes getting a very inflated large clinical effect. That's why these are proof of concept studies. Here's an example. Tamoxifen, the breast cancer drug, happens to be a protein kinase C inhibitor, was studied in mania at NIMH. Again, 58 patients assessed, people dropped out, randomization, you end up with 8 per arm. It's a little bit small, but with so few at-bats, big effect size. Now you worry, is that a type 1 error? I mean, we need replication. That means you can't go out tomorrow and say, gee, I read in the journal Bipolar Disorders that you should give everybody tamoxifen for mania because the effect size is gigantic. It's over 1. No, it's 8 people per arm. And so this is more of a hypothesis, preliminary hypothesis testing study. It needs replication with a bigger sample. It's a proof of concept study. Should inspire a larger study, but it doesn't mean go out and do this. Another example, many of us in training were taught that bupropion is a safer drug to give for bipolar depression than disipramine. Maybe you were told that. It comes from this study in 1994, which looked at the risk for switch into mania with disipramine was 50%, whereas switch into mania with bupropion was 11%. Wow, and that's significantly different. Are you impressed? Are you impressed? Well, how about the sample size? So there were 10 patients on disipramine, 5 got manic, and there were 9 on bupropion, and 1 got manic. 1 patient has influenced scores of residents over the years on the assumption that this is a safer drug to give than this with regards to switching to mania. This is a proof of concept study, and indeed later larger studies did not bear this out. So we don't negate a study like this, but we also don't run with it as a generalizable finding. And so while it's an incremental advance in 1994, in 2021, we'd say it's a proof of concept and it needs a bigger sample, right? Another notion, active placebos. You ever wonder, ask the patient, do you think you're on active drug or placebo? And would that influence things? So here was a famous study some years ago looking at omega-3 fatty acids in bipolar disorder. It did find a difference in the primary outcome measure. Notice there were 4 people per group, but the active intervention was omega-3 fatty acids fish oil. And as the authors pointed out, a distinct fishy aftertaste was episodically reported by subjects in both groups, more often in those taking omega-3 fatty acids. So you could break the blind, and that might have an influence. Or suppose you're giving a very sedating drug. Some patients will say, I have no side effects, I must be on placebo. We therefore sometimes talk about active placebos. That would mean, let's say you're doing a ketamine study. You might use midazolam or benzodiazepine as the active placebo, the comparator, not to see if it has a benefit, but just to blind the patient and the investigators so that they're not thrown off. So you're reading a study, you want to just know what the placebo was and if there was a giveaway. Dropout happens. Here's a summary of studies with just dropout rates in this is in bipolar disorder. So patients often don't finish. Here's a 100-week study with aripiprazole, 9% of the patients finished. Divalproic study, 38% finished. Lamotrigine, 17% finished. Right. So in some ways, this stands to reason. If people are not getting better, they drop out. But completer analyses are a fraction of the intent to treat sample. So we always like to see the intent to treat sample. That's everybody at the starting gate. And then we don't know what happened to them. Because if they drop out, why is that? If there's data missing, is it because there's no systematic bias that is missing at random, or completely missing at random? So absolutely no bias, like, well, the more suicidal patients dropped out or the more severely ill patients dropped out, because now you can't compare people at the end. Some studies just report what are called completer analyses. We don't like those, or pro-protocol analyses. That just says whoever made it to the finish line we'll look at. That doesn't tell you much. We don't like those studies because they really are enriched for who does well as opposed to what happens to everybody who gets randomized. Last observation carried forward, another way of dealing with attrition, LOCF analyses. That means, well, whenever you dropped out, we'll just take that data point and move it forward. That's better than completers. It's not as good as taking everybody. And so this gold standard we nowadays think of are mixed model repeated measures or generalized estimating equations. These involve statistical inferences or imputations about all subjects, all their data points for as far as they went in the study. So you're not biasing yourself with people that made it across the finish line, nor are you limiting yourself to information about people who dropped out at whatever point they dropped out without knowing about late effects that might have occurred. So we're very enamored when a study uses a more sophisticated measure like this for dealing with attrition. Primary and secondary outcomes are really important to pay attention to. So you have to specify what you're looking at. Here's an example. This is a study of lamotrigine and rapid cycling bipolar disorder. Some of you may say there's research supporting its usefulness in rapid cycling. Here's the study. Look what happened. The primary outcome was survival in the study till the time to need to intervene for an impending episode with any additional pharmacotherapy. This was not a significant difference. It was a negative study. But on a secondary outcome, survival in the study, did you stay in the study longer? It was significant. To the author's credit, in the abstract, they specify this. They don't mislead us. They say, the difference between treatment groups in time to additional pharmacology, the primary outcome, was not significant. However, survival was significantly better in the study. So this is a very legitimate way to do this. If you're the reviewer, you'll like that they said this, and you'll be very unhappy if they left out the part, or if they just seized upon the secondary analysis without acknowledging that this was a negative study. Here's another example. This is a pharmacogenetic study published in 2019, looking at whether combinatorial pharmacogenetics could yield better symptom improvement in depression than without guidance from that. The specified primary outcome was a reduction in Hamilton depression scores, and it was not significant. Okay, it's a negative study. Are we done? No. The authors went on to look at additional secondary analyses, 25 to be exact, and 2 of them, response or remission, were significant. And this became a highlight of the study. Is that all right? I mean, these are actually nominal p-values. Remember Bonferroni, if we were really going to say we did 25 analyses, so we took 0.05 divided by 25, we don't come out with a p-value of 0.01 or 0.007. It's a lot smaller than that. So at best, you could say this is a negative study, which generated some hypotheses about possibly greater response or remission with nominal p-values. But if one was reviewing this paper and the main finding was response and remission were higher, that's not, you can't do that. Right. The primary outcome was negative. All right. Let's move along and see if we can finish up. Notion of enrichment. Cherry picking. Dr. Andrade talked about this in one of those earlier slides I showed you. So here's a study saying, if you have bipolar 2 depression, you will stay well longer with fluoxetine than you will with placebo. You'll even stay well longer with fluoxetine with lithium. Oh my God, how did that happen? Well, it happened because you had to be enriched for initial responsivity to fluoxetine. Cherry-picked sample. Now that's okay. It just means you can't generalize. You can't actually take this paper and say any bipolar 2 disorder patient will fare better with fluoxetine than placebo or lithium. The caveat is if they got all better early on, and as we can see here, there's about 1 out of 2 on the front end who were acute responders. So that's okay, but it's just a slight detail that has to get emphasized, hopefully in the abstract. You as the reviewer will want to sort of be very clear, gee, do the authors adequately emphasize that this is an enriched sample for acute fluoxetine responders who didn't get manic, and they and only they did indeed do better. So it's a more detailed nuance. All right, we're in the home stretch. Meta-analyses. So we take a bunch of studies and try to increase your collective power by having a larger number of patients and then asking generalizable conclusions about usually an intervention. So a few things to be aware of when you're looking at a meta-analysis. You're interested in whether the studies were heterogeneous or not, and how much the characteristics of the patients in the different studies are mixable or not. There's this value called an I-squared, and low means good. They're not that heterogeneous, meaning, yeah, they're apples to apples to apples. If you get a high I-squared, like over 0.75, then you start to think, you know, you're combining bipolar 2s with bipolar 1s, with rapid cyclers, with treatment resistant, and then you get a mushmash. When you assume that the characteristics are fairly similar because the I-squared is low, you can use what's called a fixed effect model. But if you can't assume that, then you have to use a random effects model. And this is illustrated in this study from a few years back. This was asking, are antidepressants a risky proposition or not? What's the risk of getting manic or hypomanic with an antidepressant? And so here's a meta-analysis published in a major journal. And on the whole, they said that they were safe. The meta-analysis favors the antidepressant, but there's a little problem here, which is heterogeneity. So look at all these patients. 72% of them came from just one study, and you really can't, in good conscience, do a meta-analysis when a vast majority of your subjects come from just one study. The I-squared is fairly high, and they used a fixed effect model, and they probably should use a random, not a fixed effect model, because so much of the variation came from this one study. So it's just one example of, I didn't read this paper. I don't know. I'm not sure I would have taken it. All right. Let us finalize now. Just a few last points. I know we've covered a lot of material. Hopefully this is useful. What to do when writing a review? Cite the strengths and weaknesses. Place the work in the context of the broader literature. Feel free to speak to your enthusiasm. This is a very well-written piece, one of the best I've read. Think of it like you're evaluating a house officer or a trainee. And it's not a letter of recommendation, but it's, they're really outstanding, really thought-provoking, really, made me think. Likewise, you can point out ambiguities. I really wasn't sure what they were getting at. There were a number of points that need clarification. Were the authors to submit a revision, I might suggest the following modifications. You like to talk about whether it's compelling. I will sometimes see papers where the reviewer says it's publication worthy, but that doesn't really help me account for, does it make a contribution? Is it more than just acceptable? Journal space often being limited, especially in high impact journals. And is this paper appropriate for this journal? If it's more geared toward a specialized journal, you might suggest it's an acceptable paper, but I'm not sure that, as I know the audience for this journal, this is suited or not. What not to do? Please don't write a 1 to 2 sentence review praising the work and advising a dispo without any explanation. This is an excellent paper. I would accept it. Is not helpful to an editor, and rather you decline the invitation to review. We really look for substantive comments, critical thoughts. Likewise, a curt sentence, oh, it's a terrible work, I hate it, and no discussion. You don't have to write a book, but just here are the strengths and weaknesses. Same as you would with a patient, pros and cons, strengths and weaknesses. Don't just summarize what the authors did, but certainly it's customary at the beginning to say, Goldberg and colleagues conducted a prospective randomized trial of tap water versus bottled water on suicide risk in patients. They found the following. This is a topical area. Here are my thoughts, and then dive right in. Don't tell the author that it's being accepted. You don't know that. We don't know that. They don't know that. Just speak to the content. Certainly can phrase things in a conditional. This would be a much more compelling paper if the authors did an exploratory analysis, a moderator analysis, controlled for something. I thought there was a confounding effect of medications or patient subtypes, or duration of the trial was not long enough. So here's where you can really be so helpful in critiquing comments. Here's my final slide, your checklist. Well-stated hypothesis. Study was designed to test that hypothesis, or else if it's a post hoc or secondary analysis, acknowledge that as a hypothesis generating, not a hypothesis testing study. Is it the right design? Is the sample well described? Diagnoses were based on, look bipolar to me, as opposed to semi-structured interview, prospective versus retrospective. Was there any ascertainment bias? We only looked at treatment-seeking patients versus all comers, so on. Was the study powered? Is it proof of concept or more definitive? Is it a replication? Were confounders identified? How they deal with dropout? If it was a longitudinal study, are the results valid? Is there a contextual discussion of the findings relative to the broader literature? And finally, does this piece really advance knowledge for the field? Does it make an impact, or just an incremental contribution? These are all the helpful things that you as a reviewer can do to make the literature better. Thank you for listening. This hope was helpful.